Hello, guys. Welcome back. This week, um, luckily the anatomy itself isn't that much, hopefully. But yeah, it's last week was a lot of introduction and I guess just going through a lot of the basics in a way. And I did not put any of the bones other than the clavicle and like the scapula, I think last week, and the humerus, just because I thought you guys didn't learn the radius and the ulna in the first week, but apparently you guys did. So sorry for that. I did have it in these slides, so we'll go through them today. And also, I'm not 100% sure, but I do think last year we did it in 3 weeks. We did the upper limb in 3 weeks, I think. Except I think this year you guys are doing it over 4 weeks. So it's like a bit less content each week, which is good for you guys in a way. So keep that in mind. I will try to finish these upper limb notes hopefully by Wednesday and just upload them on the topic slides. So if you guys do want to get ahead and just look through the notes that I had made and previous PSPs did, which I correlated with, then have a look at that. But that should be finalized by Wednesday. All right. So just before as we start, so I think this week you guys are going to learn about humerus fractures or just fractures in general. We did this in ICL from memory. I'm not quite sure if we actually did it during the lecture. Maybe we did. But these are the different types of fractures that can occur. A lot of these would depend on how the force is applied. And I don't know if it's really that important for you to understand exactly what the different shock fractures are, but just do keep in mind that there are these type of fractures.
Yeah, just a point with that quickly, sorry, Peter, is there's a couple of things that are a little bit more important. So for example, the green stick fracture is something that's most likely going to happen in children. So a clinical case with a child fracturing the shaft of the humerus often will be a green stick fracture because their bones quite aren't as strong yet. They haven't calcified and fully formed yet. And depending on these other fractures, whether they just have little cracks like that or whether they go through, can depend the neurovasculature that will damage underneath, which Peter will go into more detail in a second.
Yeah. So yeah, honestly, if you really had to know one thing from fractures, is really the clinical part of it. So what is near the bones that's being affected, what could be affected by it. So for example, in the humerus fracture, firstly, it's really common in people, especially elderly people with osteoporosis. That's because they have brittle bones. And causes, one of the most causes is what we call a fush. It's a fall on outstretched hand. That's what FUSH stands for. And it's basically when you fall on with your hands kind of outstretched, and this will kind of have direct trauma going up your bones and eventually possibly all the way to the humerus. It could also be due to just direct trauma to the humerus itself, a direct blow to the torsion of the arm as well. So more importantly is the structure that's damaged here. This will depend on the fractures. This will depend on where the fractures occur. So if you guys remember last week, we went through I had notes on some of the important landmarks within the humerus. And the most important thing is what kind of things travel through it or within it. For example, at the surgical neck, there's the axillary nerve and the circumflex artery. So for example, if you had a fracture at the surgical neck, which is the most common one, you will affect and possibly damage the axillary nerve and the circumflex artery. Then this will mean you will have damage to the structures that it innervates. For example, the deltoid and the teres minor. That's why the clinical signs will be parallels of deltoid and teres minor. Also, you won't be able to actively move the arm, which means the patient is doing the movement themselves, and only passively move the arm, which means the doctor or someone else will actually move the arm for them. You also get paresthesia or anesthesia over the ridgemental badge, which is this area, which is also supplied by the axillary nerve. So I did try to color code these to show you which one kind of matches up with which, because the surgical neck will kind of end up with these clinical areas, signs. Honestly, at the start, I try to just memorize individual ones, not really thinking about the links, but it's way easier if you just remember that the clinical signs will show up because of the damage of certain structures. And those structures will be damaged because of the fact that they travel through these places, which will be fractured. So always keep that in mind. There's also the mid shaft, which is also where the radial groove is. If you look, I don't think you can see here because it should be to the posterior end, but it's at the posterior part. And this is where the radial nerve and the profunda brachii artery go through, and they're very close to the bone, really tight against it. So when there's a direct blow and torsion of the arm, this will most likely result in a wrist drop and sensory loss to the dorsal hand, because that is what the radial nerve and the profunda brachii also supply in effect. Also, if it affects the distal end of the humerus, it will affect the median nerve, and hence it will have clinical signs of median nerve damage. And if it's affecting the medial epicondyle, which is at the end over here, then it will affect the ulnar nerve. Now, just one way to remember, again, when we talk about medial and lateral, it also matches up with radial and ulnar, which we'll go through a bit later. So those are another things to help you. Okay, there were also spaces that I did have in last week's slides, but I put them in again because they were in your notes, especially quadrangular space and the triangular space. And they did specifically mention the different boundaries and the borders. So I put them here for you. They are relatively low yield. Just remember, the quadrangular space has the axillary nerve and the posterior circumflex humeral artery passing through here. Okay. All right. Okay, I kind of just explained it. So actually, I'll still give you guys a go. Try have a guess. I mean, I did write it down just then. But right, pretty easy. I kind of just explained it, but yeah, just do remember that. That's probably the most important thing out of that slide before. Okay, so now we're going to move on to some forearm bones. So we have the humerus, obviously, which is a big bone, and then that is linked up with the radius and the ulna, and they're two separate bones. The radius is the lateral bone. So if you remember what lateral is, it's away from the body compared to the other one. Okay, so this is a lateral bone, and the joints it has is the elbow, radial ulna, and the wrist. And the function is it pivots around the ulna and produces movement at radial ulnar joints. And the shaft is triangular and expands in diameter as it moves distally. So for example, if you look over here, this is the anterior view. Obviously, you can see this is the radius. You can see how the shaft becomes bigger as it goes down. That's a characteristic of a radius, so the radius. Okay. I do have on the next slide some landmarks of radius. That's pretty important. At the proximal end, you got the head of the radius, which articulates with the capitium of humerus, and this is where the elbow joint is. It also articulates with the radial notch of ulna, which makes the proximal radial ulnar joint. So if you look here, or you don't see the humerus here, or you kind of do, but I know you don't, never mind. But you do have the radial notch over here with the ulna, and this will form the proximal radial ulnar joint. And the reason why it's called proximal is because if you look here, there's also a distal radial ulnar joint. So the two bones have two different joints, proximal and distal. Again, proximal is closer to your body, and distal will be further away from your body. The neck of the radius, this is where this is area between the radial head and the tuberosity, and the radial tuberosity is attachment site for biceps brachii muscle. Distally, you have the ulnar notch of the radius. If you look over here, ulnar notch over here. Again, ulnar notch of the radius. So it's part of the radius bone, just called ulnar notch. This articulates with the head of the ulna to form the distal radial ulnar joint. So very similar to the proximal part, just with different ulnar and I guess radius words. So just be careful to not mix them up. Radial stylo process. This is located laterally, attachment site for tendon of the brachioradialis, which is a muscle, and attaches at its base. And the radial collateral ligament of the wrist also attaches at its apex. The roughening on the lateral surface is a site of attachment for pronator teres muscle, and the radius directly articulates with the scaphoid and the lunate, which are some carpal bones you will learn next week. Okay, so.
Yeah, Peter, could I just add something?
Sure.
So just one more thing to add in there is there's an important feature of the radius that they often ask about. So the radius, there's the head of the radius, and that's often covered in something called the annular ligament. And the annular ligament allows this, this radius bone to kind of move over the ulnar bone, which is what facilitates pronation and supination. So visually, when you look at these, the way to know if you're looking proximal or distal is if it has this little really neat sort of circular head, that's the radius. And if it doesn't have that, then the other side of it will be the radius on the other side, on the distal side. Yeah. Does anyone know what the major supinator is of? It's also involved in flexion, but it's a major supinator. Sorry, major pronator. So it's the biceps brachii. It attaches down there, and that's involved in supination as well. Sorry, pronation as well.
Pronation, yeah. No, biceps brachii, yeah. Isn't it supination?
When I lift my hand up, it goes, yeah, you're right. Supination.
It's just confusing, but yeah, you guys will get the hang of it.
Let me search it up, sorry.
Okay. Yeah. All right. So while David's searching that up, I'll just quickly go into Colles fracture, which is relevant to the radius because it is a complete transverse fracture of a distal 2 centimeters of radius. The distal end of the radius is being fractured, and this will lead to the posterior displacement of the distal radius. And the wrist and hand will move posteriorly. So normally it occurs again on a fush, so fall on an outstretched hand, and you can see how the radius moves. That's not good. I think this is a better picture here. If you look here, this is the radius, this is the ulna. Radius is bigger on the distal end, so that you can see how it's wider than the ulna here. And if it does get fractured, it can go posteriorly. And it also causes a thing called dinner fork deformity, which will make it look like it's kind of like a fork. And the reason is because the radius is now technically shorter in length because it's being fractured. And this will lead to the hand looking like this. It's also very common in people with osteoporosis. Another one is Smith fracture, and they're very, very similar to Colles, but instead of a posterior displacement of distal radius, it's the anterior displacement. And this will be falling on the back of the hand like this. So it's less common because normally when someone falls, the instinct is to kind of fall out on the outstretched hand. So fush is way more common, but it can be possible to have a Smith fracture. Yep. Okay, so now the ulna. So the ulna compared to the radius is different because it's actually a stabilizing bone. So it doesn't actually really do much of movement itself. And this is also, the shaft is also triangular, but it decreases in width as it moves distally. So before, the radius would get bigger as it goes down, but the ulna really doesn't. It kind of decreases instead. So that's how you can tell the difference between radius and ulna at the distal end. The bigger bone is basically the radius. These are some important landmarks of the ulna. So you got the obliquum process, cannon process. This is the most proximal part of the posterior ulna, which is this part right here. And the anterior surface, which will be here, of this area is what we call the trochlear notch, and this is attachment for triceps brachii muscle. Okay, and then the trochlear notch itself will articulate with the trochlear of humerus. That's why it's called the trochlear notch. And it has two parts, larger medial and smaller lateral, and this is divided by a vertical ridge. You also got the coronoid process, which sits anterior to the trochlear notch articulation. And this is the anterior ridge of the bone. Now, the ulnar tuberosity is the roughening distal coracoid process, and this is where the brachialis muscle attaches. The radial notch of the ulna articulates and forms proximal radial ulnar joint with the head of the radius. Okay, now at the distal end, has the head of the ulna, which is over here and here. Articulates and forms distal radial ulnar joint with the ulnar notch of the radius. Ulnar styloid process is located medially because obviously the ulnar bone is medial, and it's a small projection of the bone. So more importantly is kind of, obviously the clinical part of it. And this one has two, the Montigia fracture and the Gell-Arzi fracture. So the radius and ulna are attached via interosseous membranes. If you look in the previous slide, you can see these interosseous membrane, they're attached by it. So because it's attached, when the force hits, it transmits across two bones, right? I don't know the exact physics, but obviously just because it's attached to it, probably just the force kind of spreads. So commonly, if there's a force applied to the forearm, both bones can be fractured. But if it is just only one of them, then you've got two different types. We got the Montigia, which is a fracture of ulnar bone, okay, the ulnar bone, and the dislocation of radial head, which is what we call the proximal ulnar shaft fracture, because if you look here, the radial head was over here, right? This is the proximal radial ulnar joint. So the mnemonic that this lovely picture has is called the MUGA. So Montigia has ulnar fracture, so MU, and Montigia is A, and A is closer than Z, so A is proximal, so affects the proximal ulnar joint, or our radial ulnar joint, ulnar radial joint. Head of the radius is displaced anteriorly. Now compare that to the Gell-Arzi fracture. It's the fracture of the distal part of the radius with the dislocation of the distal radial ulnar joint. The ulnar head dislocates again because the ulnar head is what is articulating with the ulnar notch of the radius at the distal radial ulnar joint. Therefore, the GR is G for Gell-Arzi, and obviously the radius is fractured this time, so GR. It has the Z, which is obviously further away from the A in the alphabet, distal, so the bones are affected distally. And the cause is normally a blow to the distal end of the radius. Okay, so now this is just a slide that I put in. I'm not quite sure when you guys learn it, but you will probably need to learn about it in the end. This is just talking about the shoulder joint mobility and stability. So we talked about the shoulder joint last time. And if you remember, it's a ball and socket joint. And one of the pros about a ball and socket joint is that there's a lot of mobility. But obviously then at a cost, it's low in stability. So there's a lot of body structures that help to kind of stabilize the shoulder joint, which will include the rotator cuff muscles, the sits muscle, which is what we call the dynamic stabilizers. Yes, these surround the glenohumeral joint and fuses with the joint capsule. The resting tone, so it's basically without doing anything, these muscles actually just compress the humeral head into the glenoid cavity, which increases the stability. And then there's the glenoid labrium, which is something that you guys probably need to know. It's a fibrocartilaginous ridge which surrounds the glenoid cavity, and it deepens the cavity. And this will create a seal with the head of the humerus, again, trying to increase the stabilization and decrease the risk of dislocation. There's also ligaments around it, which are non-contractile, reinforces joint capsules, and this forms the coracoacromial arch. There's also the biceps tendon here, which is also a depressor of the humeral head, and the shoulder girdle muscles, the pec muscle, latissimus dorsi, the ones we talked about, all play a role in joint stability, especially in diverse movements. Now for mobility, we talked about the ball and socket joint. There's also the bony surfaces, so kind of where they actually articulate. So we've got the shallow glenoid cavity, but then you got a very large humeral head. So it's kind of like a golf ball on tee. It kind of allows for a lot of mobility, but then obviously you can think about it as very low stability. Joint capsule, also it's very inherent laxity, which means high mobility. Yeah. So important thing is the shoulder joint is very highly mobile, but then therefore less stable. So it's the most frequently dislocated large joint in the body. So extreme range, but at the expense of instability. So when do you actually get a shoulder dislocation then? well, normally it dislocates anteriorly. 95% of the dislocations of shoulders are anteriorly. And this is because the coracoacromial arch, which we talked about, and the rotator cuff muscles are very effective in preventing upward dislocation. So it just kind of goes anteriorly because it can't go up because of the supporting structures. And also, the main cause of shoulder dislocations are from excessive extension and lateral rotation. And what this does, it drives the humerus inferior anteriorly, which is the weakest part of the capsule. Okay, and this is kind of what could happen on the right here, the image. It's really common in people who kind of throw things like baseball and stuff like that, because that's the motion of excessive extension and lateral rotation. And possibly it could lead to a shoulder dislocation. Now, because of the structures nearby, the damage that it can do when the shoulder dislocates is affecting the axillary nerve because it's very close in terms of where this location, this shoulder joint is, and the radial nerve, because even though it's not near here, it sits on the radial groove, which could be stretched because the humerus is also being dislocated. Symptoms, therefore, will be pain in the arm and shoulder, just because of the fact that you've kind of, in a way, lost or teared a lot of structures nearby and near the shoulder joint. There's also swelling and numbness and weakness, bruising and deformity of your shoulder. So I'm going to just quickly skip through this. This is obviously anterior, which we talked about, but most importantly, this is from UpToDate, which is a fantastic website. It talked about how anterior dislocations are 95 to 97%, posterior dislocations 2 to 4%, inferior is 0.5%. So as you can see, anterior is by far the most common. Now we're going to quickly move into some arm muscles. The location of these arm muscles are between the shoulder joint and the elbow joint. These are not necessarily the attachments, but I'm just letting you know where the locations are. This anterior and posterior muscles. Anterior muscles are biceps brachii, long and short heads, brachialis, and coracobrachialis. That's 3. And the one posterior one is triceps. The thing to use to memorize anterior muscles in the arm is BBC. So biceps brachii, brachialis, and coracobrachialis. I'm not going to go through all of this. You guys can have a look at this in your own time. The point I wanted to point out here is that the innervation of the anterior arm muscles are the same, musculocutaneous. Now you do see these baldings here. This is straight from the MoM and that textbook, anatomy textbook. And basically the balding is technically what the most prominent route of the supply is. So the most dominant segmental innervation. But you do not need to know into that detail from memory. You just need to know that it's musculocutaneous nerve. Okay, all of them are that. Technically, brachialis has some radial nerve, but I think they didn't really ask a lot about that, so it might not be that important here. We talked about how biceps brachii was a powerful flexor, but also supinator of forearm. Okay, brachialis is also powerful, and it's the main flexor of the forearm. And coracobrachialis is adduction, adduction, and weakly flexors. So you can see how they all flex. At the shoulder joint, at the shoulder joint they flex, and at the elbow joint, brachialis is the main flexor of the forearm.
Yeah, I might just add something there as well. Yeah. So if we look at the coracobrachialis muscle and its relevant innervation of the musculocutaneous nerve, an important aspect of specimens and identifying neurovasculature in specimens is looking for a nerve that will pierce the muscle. And the nerve that will pierce that muscle is often musculocutaneous nerve piercing through the coracobrachialis, through the biceps brachii and brachialis. Another point to make is sometimes you're going to have to differentiate between the long and short heads of the biceps brachii. The long head, as I wrote in the chat, runs through the bicipital groove, which is between the lesser and greater tubercle by the humerus. And because of the insertion at the radial tuberosity, which we talked about, actually skips the arm, goes to the forearm. So when you flex it, it supinates outwards and pulls the radius over the ulnar bone, radial bone over the ulnar bone.
Yeah, so actually, if you can't really tell here, but yeah, this is why you don't need to know exactly the origin and insertion, like the exact points of the landmarks to be doing well in anatomy. It's really more about knowing where it is in relation to the other structures, and hence you'll be able to tell if it flexes or if it extends, whatever the case is, what will happen. It's relatively easy if you can kind of grasp your head around the origin insertion. And honestly, the best way I found was just getting a really nice picture and looking at it. And I put it in my Anki deck and just thought, okay, where is it inserting? Like I look at my arm and be, okay, it would be inserting here. I didn't really need to know exactly the actual like anterior surface of the humerus medial and lateral. I wouldn't actually memorize that word for word. Instead, kind of try to visualize it more so. But again, it's up to you guys, but I find that more helpful.
I'll just answer Hasna's question.
Okay, yep, sure.
So does the musculaneous nerve piercing through the median common to get sciatica there? So it's an interesting question. It's a bit different to sciatica. So sciatica refers to the compression of the sciatic nerve in the leg. So the musculocutaneous nerve piercing through the coracobrachialis is generally going to be fine. Maybe if you inflame the muscle, it might get, if you have a hematoma, which is bleeding in the muscle, it might get irritated. But the word sciatica specifically is reference to the sciatic nerve that passes through the pelvis. And the reason why that gets pressed down isn't necessarily because it's going through a muscle that presses it down, but it's going under a muscle that's pressing into it that can get inflamed, which is the piriformis muscle in that case. So sciatica is a particular example where it goes through the greater sciatic foramen, which is, you don't know this yet, but it goes through a particular circle that is vulnerable to getting compressed. That's not quite how piercing through the muscle works. So it's a little bit different here, but it's a good question. And I think if you had a hematoma or if you had swelling, you could have risk of musculocutaneous nerve injury, but I think it's quite uncommon.
Yeah. So I think you guys, I did put in my slides, well, you got to learn about this thing called compartment syndrome, which is like when the fascia within your, like it's like your muscles are compartmentalized. It's got structures running through it, and then it's kind of like swells up, inflammation occurs, and it presses all these arteries and nerves. Obviously, in those cases, it definitely could happen, but as David said, sciatica technically refers to the lower limb, and it's especially the sciatic nerve. Okay, so this is a triceps that I have here. I'm not going to go through too much. It extends the arm. Again, as I said, mostly all flexion here, general rule, and then posterior is extension. That's kind of the general rule. Innervation is radial nerve. If you look over here, musculocutaneous. So those are really the big differences you should really be able to know as a basis. Now, the origin, there's a lot of origins here. David, did you find these that important? I don't really remember being too important, as long as you kind of.
No, I didn't think.
Yeah. Like, I mean, I kind of did find that, like maybe sometimes when they did ask, sometimes like, oh, where is the lateral head or the long head on the specimens? But those are kind of more clear on the triceps because they're kind of like the only posterior muscle, arm muscle.
Yeah, I don't think it came up in exams.
Yeah, definitely not in exam. Just like one of those questions they had in specimens kind of thing. Yeah.
Yeah, occasionally they'll throw in what is the origin of this muscle, and like it's not that important to know, but you might know it. Another point with the triceps brachii is it's the antagonist of the flexors. So when the others are flexing, it is extending. It's not like one happens and the other one's not doing anything. They work together.
Okay. Now, the clinical relevance. This is the rupture of bicep tendon. So this normally occurs due to wear and tear of an inflamed tendon and occurs when they move back and forth in the bicipital groove, which is what David talked about. So if you look here, this is the bicipital groove. And this normally occurs in eccentric contraction, which we'll go through in physiology if we haven't already. So basically, it's like when you're tensing the muscle as you are making the muscle go longer, if that kind of makes sense. It's like when you're doing, like, for example, like flexion of the arm, as you go down, that's when you have eccentric contraction. So when you're going this way, the typical sign is the pop sound or the snap. So it's very dramatic. You can hear the pop or the snap. But even though it's really dramatic in sound, it's not actually that much in terms of weakness in muscle because the other anterior muscles do cover for it. but you will get this sign called a Popeye sign, which is over here on the right. So when you tense, a bulge abnormally comes out, and this is because the muscles, I think, they kind of like get together because they're not attached to where it should be normally, and they kind of form a bulge within this anterior part.
And an interesting point with that as well is it shows that the biceps brachii actually isn't that important in the flexion of the arm because it's a bit more superficial. So when people go to the gym and like it looks really good, it's not really what makes you stronger. What makes you stronger are the deeper muscles like the brachialis and coracobrachialis, which is why when this ruptures, you're generally actually okay to still flex it.
Okay. So I did get a question. Should we know movements by terminal branches or by spinal cord segment? For example, elbow flexion is caused by C5 and C6, and the same movement is caused by the musculocutaneous nerve. Yeah, okay. Okay, so you said which one should we choose, terminal branches or spinal cord segment? So those are myoterms. You also your spinal cord segment will be the myoterms. So the actions that the spinal cord roots will do. And knowing the terminal branches and musculocutaneous, they're both important. I would argue that musculocutaneous nerve or knowing those functions of those terminal nerves are more important because mostly they're the more clinically relevant ones. Just because that nerve actually travels through the body, whereas the spinal roots, as you saw in the brachial plexus, kind of all intertwine and then kind of becomes 2 or 3 different nerves. So I would say if you had to choose musculocutaneous, but both of them are definitely important to know. Okay, hopefully that answered. If not, tell me again, but I think that's what I would have to say.
Yeah, and also like it's always going to be difficult when you're trying to compare myoterm to the terminal branches.
Yes.
But in some areas of the body, it's a bit more obvious. So in your forearm, you have some median nerve and some ulnar nerve. So if you check in, they have problem with the forearm. It's important to diagnose whether it's a cervical problem at the nerve root, in which case you'll test the myoterms, or if it's more of maybe a compartment syndrome or more of a peripheral problem. So it's just to rule things out. They're both you have to know them both.
Yeah, so that kind of answers the question that I had next, which was, so if someone could not flex the arm, is it because of musculocutaneous or because of the actual roots? As David said, that would depend on the actual injury. So if they did injure the spinal roots, then it would affect the other nerves that it would normally innervate as well. So you test for the other nerves as well as what the flexion would do. Or it could just simply be because of the actual muscle being damaged. So it might not be related to the nerve. So there's a lot of causes. And you need to know the differences between the terminal branches and the spinal cord roots. And thus how to differentiate between that. So if that kind of answers the question. So it's kind of like, yeah. So it's more of kind of understanding the differences between them and the fact that spinal roots aren't just only flexing the arm. So you would do different tests that you would normally do.
Yeah, and you could also, it's just about clues as well. You would test the dermatomal distribution of the spinal roots as well to see if there's any issues there.
Yeah, so you do a lot of different tests for some of these things. Okay, so the muscular compartments, which is something I just talked about before, is that the fact that muscles can be compartmentalized into posterior, anterior, and I think also lateral sometimes in the leg. Not quite sure if it's in the arm as well. But this is due to the deep fascia, which forms the septa and divides the muscles. So the pros of this is that it keeps the muscles in place and also it's compartmentalized. So for us, it's also easier in a way. A lot of like anterior muscles flexions, posterior muscles extension, like there's a lot of general rules that come from it. However, the cons are that if there is inflammation or bleeding within these compartments, this will increase the fluid, obviously, then it will increase the pressure. The reason why it increases the pressure is because fascia does not stretch. It's not stretchy at all. So when there's a buildup of fluid, there's got to be a buildup of pressure because it's not expanding in any form, but there's more things inside it. This will lead to damage to structures within it. And most importantly, it will most likely block the circulation because arteries and stuff will be passing through it. This will lead to tissue death and nerves also will be damaged, which is what we call the compartment syndrome. There's also a very important law that comes up because of the muscular compartments, which is called the Hilton's law. It's basically saying that a nerve that supplies a muscle producing a movement at a joint will also supply the joint and the skin overlaying the insertion of the muscle insertion. So there are exceptions, but basically, if there's a nerve that supplies this muscle, it will also supply joints and the skin around our rescue right next to it. So now we're going to go into forearm muscles. There's anterior and posterior compartments within the forearm muscles. This is really the general picture of how to approach anatomy in general. And this is to find the general rule, or at least kind of the general idea of which and what each compartment is supplied by, what it does. So in this case, anterior compartments flex. So they flex at the wrist, fingers, and they also do pronation. Posterior compartments, they are extensors. So extend the wrist, fingers, and they do supination. However, there is one exception. There is one flexor, so one muscle that does flexion within the posterior compartment. There's also superficial and intermediate compartment within the anterior compartment, and they all originate from the medial epicondyle. Whereas the posterior compartment, the superficial compartment, all originate from the lateral epicondyle. Anterior innervation is mainly medial nerve. Some are ulnar, but mainly medial. Posterior are all radial innervation. There is no exceptions. The muscle origins. This is another general rule. Superficial and intermediate compartments tend to originate from medial/lateral epicondyles, depending on if it's anterior or posterior. D compartments tend to originate from interosseous membrane or surface of ulna or radius, depending again on which part of the muscle or compartment it is under. So if you guys can understand this general picture, it will really help you get yourself and figure yourself around in anatomy. Because understanding and trying to memorize every different muscle and attachment and innervation is kind of being a waste if there's a very clear common traits among these compartments. So these are some helpful tips. I think. Oh, yeah, okay, yeah. If there's a longus present, there's also be a brevis. That's kind of like a very general tip. And in anatomy, it's very logical in layman. For example, if it's ulnaris, it will move towards the side of the ulna or medial side, and therefore it will adduct. If it's radialis, it will move towards the side of the radius, lateral side, and it will abduct. Again, as we said, compartments will exist. General rules are present, but there are exceptions, which you will need to know as well. They will ask you about exceptions. Mirroring occurs a lot, and what I mean by that is if there's a flexor carpi ulnaris in the anterior compartment, there will be an extensor carpi ulnaris in the posterior compartment. Okay, and as we know, flexor is a flexion, and we talked about how that's anterior compartment. So you might need to only memorize that flexor carpi ulnaris, and you will know all of this for, because you know extensor will exist, and you know flexor equals anterior, extensor equals posterior. So that kind of helps you decrease your need to memorize individual ones if you understand the big picture. Also, obviously, knowing some Latin helps in general in medicine, but especially in anatomy here. Longus equals brevis. Longus means long, brevis means short, so the muscles itself. Superficialis means superficial, profundus means deep. Pollicis equals thumb. Digiti minimi means the little finger, pinky finger. Digitorum means fingers. Indices, peripherus is index finger. Also, profundus is normally distal and superficial is proximal. I had that in my notes, so I didn't. It's under the speaker notes. Okay, so now we're going to go into the anterior compartment of these muscles, especially the superficial ones. So there's 4 muscles in the superficial part. If you look over here, so we've got the flexor carpi ulnaris, right, which does flexion and adduction at the wrist, because obviously you can see how it extends all the way to the wrist. So if you were to think about this being contracting, then you can see how it would also kind of flex the wrist, because this is the anterior part. You also got the palmus longus, which is the blue muscle here, also flexion at the wrist. Flexor carpi radialis, which is also flexion and abduction at the wrist. And pronator teres, which is pronation of the forearm. So you can see how this doesn't really insert all the way there. Well, actually it does from memory. Yeah, so it goes all the way to the distal surface of the radius. So it kind of goes around like this. Hence, once it contracts, you can see how it kind of pronates the arm. Innervation, again, we normally said the general innervation is median nerve. So the exception here is flexor carpi ulnaris, which is innervated by the ulnar nerve. So that's one way to memorize ulnaris innervation, ulnar nerve. And the rest of the three are all innervated by the median nerve. Arterial supply is generally ulnar nerve, and the peroneal artery is also supplied by radial artery. So this is just the table that I have here. Again, all of it kind of originates from the medial epicondyle. Innervation, don't need to know again too much exactly, but just do know where it inserts in terms of, is it near the wrist, is it further away from the wrist? Just so when you do know that, you just think, oh, if I contract it, does it do this action? Does it flex? Does it AB duct? Things like that. Okay, this is the intermediate anterior muscles. So sometimes they do classify this as superficial, I think. And the name itself is also flexor digitorum superficialis. But you can't, I think we learned it as intermediate muscles. This has flexion, again, flexor. So it's pretty straightforward in the naming at these joints, which is the fingers. This is supplied by the ulnar artery. And again, median nerve, which we talked about, is the general one for the anterior compartment muscles in the forearm. Yes, and then the deep muscles. If you look here again, there's flexor again, just because it's anterior compartment, flexor digitorum profundus, a lot of words that we talked about before that you can use to kind of decide what they do, flexion. If you look on this lovely picture here, you can see how the flexor digitorum profundus goes all the way to the joints, which of the fingers here. So they do all these movements at the joints as well as the wrist. Flexor pollicis longus is this red muscle, flexion at the joints as well as the thumb. Pronator quadratus pronates the forearm. Again, the name is pretty self-explanatory. Innervation is on the nerve, medial half of the flexor digitorum profundus, and the median nerve, or this branch of the median nerve, supplies the lateral half of flexor digitorum profundus and the other two muscles. Again, this is the main or the general nerve here, and the ulnar nerve is kind of just the exception. This will be pretty important to note that the flexor digitorum profundus has an exception here. I'm pretty sure I got some questions when I was doing some past questions here. Arterial supply, ulnar artery, it's pretty important to know as well. And also the lateral part of flexor pollicis longus is supplied by the radial artery. This is again, just a nice diagram or table. Nothing too much important here. Okay, posterior compartment. We're going to go through the superficial ones. There's 6 muscles here. This muscle right here, brachioradialis. If you can see on this right side, it's this muscle right here. It has the, if you look over here on the next slide, it has the origin and insertion and innervation of an extensor, so of a posterior compartment, and it is part of the posterior compartment, but it actually flexes the elbow. So it's paradoxal. Very important to know that. It is technically part of the posterior compartment, but its action is what a flexor would do, flexion of the elbow. Okay, and these names, again, now instead of flexor, they're all extensor because they're posterior compartments. Extensor carpi radialis longus and brevis, extension and abduction, extensor digitorum, extension again, extensor digiti minimi, extension, digiti minimi, little finger, extension at little finger. Extensor carpi ulnaris, carpi does mean, I believe, wrist from memory. So if there's carpi, probably to do with the wrist, also extensor carpi radialis, wrist. Extensor, again, extension at wrist. And coneus, extension at the elbow, stabilizes the elbow joint. Innervation, again, we talked about this. All of them are radial nerve. Just all of them. Don't even need to think about it. Posterior compartment arm muscles, radial nerve. Okay. Arterial supply, radial artery, everything but this, and the ulnar artery is the last 4. So that means the last 4 has both radial artery and the ulnar artery. So extended digitorum, digiti minimi, carpi ulnaris, all have ulnar and radial. And coneus only has ulnar, and the first 2 only radial artery. Okay, there's no intermediate in the posterior compartment. We go straight to deep, and there's 5 muscles. Supinator, name is pretty straightforward, supination of the forearm. Abductor, again, probably abduction. pollicis longus. I believe pollicis is thumb, right? I think so. So that's why abduction at the thumb. Extensor pollicis brevis, extension at the joints of the thumb, basically. Extensor pollicis longus, again, extension at all joints of the thumb. Extensor indicis proprius, extension at index finger. Indices is index finger. So if you look at the diagram here, you can see how the supinator kind of curls around, kind of like how the pronator teres kind of curled around. It's all due to the fact that it needs to insert in a place where if it contracts, it supinates. If it's attaching here, it probably won't be able to supinate. So it needs to curl around a little bit. Yes, as you can see, a lot of these insertions are to the thumb because they actually do the movement at the thumbs. Again, innervation, radial nerve, don't even need to go through that, straightforward. Ulnar artery is the arterial supply for AB ductor and the 3 extensors. So these 4, and the radial recurrent artery, posterior interossseous arteries are the supinator. Anything here? Not really. These again, don't be too dived into origin and insertion. Just do know roughly where they do. Sorry. Okay. So memorizing the origins and insertions just for the sake of understanding the movement. Okay, it's not like they won't ask about origin and insertion at all. I can't guarantee they won't ask at all, but it is very unlikely that they will just be like, for one question, what is the origin of? It's like, that's not going to be an exam type question that they will give you. Right, David, I think?
Yeah, but what you might need to know is that if you have a muscle and it's in the anterior compartment and it's a flexor, you have to know it originates at the medial epicondyle.
Yes.
There's certain stuff like that you need to know. And the big muscles that they mention a lot, it may be beneficial to learn the attachments, although I don't think so. But
yeah,
the big concepts, like you might need to know, because brachioradialis was the exception, you might need to know a bit about that.
Yes,
But learn them. They want you to know that, and the medial epicondyle stuff and lateral epicondyle is clinically relevant as well. That's why those meetings.
Yeah. So the main point there is the reason why they would ask you or want you to know certain insertions or origins are all because of clinical relevance. Like they will not ask you, because we're not like mastering in anatomy, right? It's a medicine course, right? Medical course. So they're not really too fussed about you knowing exactly what each muscle attaches to, exactly where the tendons are. They really want to know and want you to know the clinical relevance of it. If it was to be damaged over there, what would happen? And you will need to know the origin and insertion because that will allow you to locate yourself within the body. So that's that. Also, another question was, may I know why flexor digitorum profundus does not flex the proximal interphalangeal joint? So I think that was over here. Okay, so why not the proximal inter? Ooh, okay.
Because the superficial one does that.
Okay. That's very, yes, okay.
It might have some action on it, but it's mainly the superficial. Clinically, you test that as well. You put your hand, you can't see what I'm doing. It's inverted, it's so hard to orientate. You put your hand there and you ask them to do their distal phalangeal, and that's your deep one. Superficial, you move your hand down and ask them to do that.
Yeah. Okay. Yeah, so keep asking these questions.
Flexor digitorum superficialis when I say superficial. That wasn't clear.
So we went through that. Yeah, okay. So again, this is not a table that I won't go through too much. Yeah, there's nothing that important there. Okay, so now I have some slides on the motor functions and sensory functions of some of these nerves. So firstly, we're going to go through the musculocutaneous nerve. Obviously, the motor function is that it supplies obviously all the muscles in the anterior compartment of the forearm, of the arm, sorry, the BBC. Therefore, it's responsible for flexion and shoulder and elbow, and biceps also supinates the forearm with other muscles. So obviously, the motor functions of nerves are more for like, what muscle does it innervate, and what actions do those muscles do? So it's not really that the nerves actually, I mean, they do, but like it's basically what it innervates. Sensory part is the skin on the lateral side of the forearm over here. So the sensory ones are relevant in clinical sense because, for example, if you do damage the musculocutaneous nerve, it will have weird like tingling feelings or things like that on the lateral side of the forearm. So if any patients report on those symptoms, you will need to think about, oh, is it damaged? Is our musculocutaneous nerve damaged? The median nerve, this is most of the anterior superficial intermediate compartments, as we talked about. The anterior interosseous nerve is the most of the anterior deep compartment. So I believe that's a branch of the median nerve. The actions it does, obviously, is because of the fact that it supplies these muscles, innervates these muscles, pronation of the forearm, flexion of the wrist and digits. Sensory functions are the 3.5 digits. So that's from the thumb going to the pinky finger.
I might just make a point here as well.
Yep.
So you see how these cutaneous branches, like they seem insignificant, but one reason why they are important is there's a condition called carpal tunnel syndrome that refers to the compression of the median nerve at the wrist. And an interesting thing about that is that the palmar cutaneous branches branch off proximal to the carpal tunnel, and so they will not be affected in carpal tunnel syndrome, whereas the digital cutaneous branches will be. Yep. So that's why they teach you this is for carpal tunnel.
So another question was, should we know the cause of the nerves? Okay, so I think we went through this last week as well. So David, you want to say something?
You'd say yours and I'll say mine.
Okay, so personally last year when I was going to different PSBs and even when I was technically studying it, they did say that the cause of the nerves were technically low yield, okay? As in you do not need to know exactly where the cause of the nerve goes. But I did find when I was studying, knowing the cause of the nerves did help a lot because normally it would innervate the parts that it is going through, okay? And even in cases like the carpal tunnel syndrome, knowing where the median nerve goes through will help you identify the symptoms. So should you know the cause of the nerves? I would say yes, but don't be too focused on knowing the exact details.
Yeah, I agree mostly with that. Like it's good enough to know radial is the posterior of the arm and forearm.
Yeah.
That's fine.
Yeah.
One reason why you might need to know a bit more specific is for particular clinical conditions. For example, the ulnar nerve runs through the medial epicondyle, which means a fracture of the medial epicondyle can affect the ulnar nerve. That's when you really need to know the specific cause, and generally they will teach you to those a bit more clearly than the others. I don't think it's as important. And like you need to know that the radial nerve goes through the spiral groove on the posterior for a shaft fracture because that's relevant, and it runs with the profundo brachii artery. Yeah. So like, only for the clinical stuff. The rest, they're not going to ask you.
Yeah, like even the one we talked about earlier. Sorry.
Although they will ask you to identify nerves, and for some people, knowing the cause is actually easier than just trying to figure out which muscles they're going to. So that's why we gave the example of the musculocutaneous nerve piercing through coracobrachialis.
I feel like definitely knowing the brachial plexus is definitely important, like knowing how the nerves branch off. That's very, very important to know. I feel like going all the way down the forearm, maybe not, maybe up to the arm a little bit. I doubt that they will ask you to identify nerves like in an exam in the forearm.
I don't think so either. I think that was just guessing.
Yeah. Okay. So I'll quickly try to skip through some of the last ones. So ulnar nerve, motor function. Again, the fact that it innervates these muscles will allow you to do the adduction, flexion of the wrist, and flexion of the joints as well. Sensory functions. This has a lot of things, but basically medial wrist and medial 1.5 digits. So this is the median nerve, and this is the ulnar nerve here. Radial nerve. Yes, action, supination of forearm, extension of the wrist and finger joints. Again, radial nerve is most of the posterior compartments. Well, all of the posterior compartments. Sensory functions. If you look at here, this is really the posterior part. As you can see, this is the dorsal hand. So you can see how it's basically applying sensory functions to the posterior part. And again, that explains why. That explains it because of the course that it also takes. It's posterior part. So yeah, okay.
Cutaneous. Sorry, cutaneous is also sensory of the skin. That's what the word cutaneous means. Yeah. That's why it branches, because it's more superficial.
Yep. Okay. Arteries. Oh, radial and ulnar. Again, radial is mostly posterior, so posterior lateral forearm. So there's a radial pulse, which is palpated in the distal forearm, immediately lateral to the tendon of the flexor carpi radialis. Do you think you do that in clinical skills? Ulnar artery, this mainly supplies the anterior medial forearm. Yes, and yeah, I think that's it. Okay, cubital fossa. This is important space within kind of like your elbow joint kind of area. It's a triangular shaped area depression of the anterior part of the forearm. Elbow area isn't like the anterior part, so not the elbow at the back, but yeah. You do need to know these borders. And this will in the end become this triangle here. And the contents are also very important. There's a mnemonic, my blood turns red, median nerve, brachial artery, which bifurcates into radial and ulnar at the cubital fossa. So that's a very important thing right there. If you see radial or ulnar arteries, that means that it's already past the cubital fossa. If it hasn't, it'll be a brachial artery. There's the tendon of the biceps brachii, the distal end, and the radial nerve. And the median cubital vein is contained in the fascia or on the roof of the roof.
Yeah, and I think the tendon of, correct me if I'm wrong, the tendon of biceps brachii here is an aponeurosis.
So I believe so, yes. Yes.
It's quite distinct and it looks like a flat sheet of tendon.
Yeah, aponeurosis is like a flat sheath of the tendon. I believe that's what aponeurosis actually is. Yeah. Yeah. So I don't think it's really shown here, but yeah. The clinical relevance is that at the cubital fossa, there's a median cubital vein, as we talked about. This is a very common place for venipuncture. And also measuring BP, this is where the pulse of the brachial artery is commonly felt. Okay, so that was a bit longer than I expected. Again, I'll try to finish the anatomy slides by this week. So have a look at that if you want to go ahead. If you have any questions, keep asking in the chat. Otherwise, we'll move on to some HLSD.
Yeah. Just before we do that, what I might do, just while we have everyone here, is could you text us or write to us and tell us if you think it would be more convenient to you to have short videos on demand for you to watch in little sections instead of the live sessions, or if you like the live session, you like the live sessions more than having short things on demand, you like that circumstance. Just if you don't mind letting us know so we can know whether we should transition or not to be more helpful for you. Take your time to do that. Maybe private message me, and while you do that, catch you.
Thanks, David. So yeah, this is like one of the few times the fluffy stuff is actually examinable. This is our first lesson in HLSD. Did come up in exam questions a few times, and I'll just try to make it obvious which part was like definitely tested on. All right, next slide. Oh wait, should I change slides maybe? Oh no, sweet, thanks Peter for who that was. And yeah, private message Peter to get that info across to us. So this is sort of the first 2 weeks I'll be covering of HLSD, and you only have another 2 weeks. So it's actually not too much. You have kind of 4 lectures for, I think in the exam were like about 6 or 7 questions. So you can expect sort of 1 to 2 questions per lecture. Lovely, next slide. This is just a brief outline of all the learning objectives, and pretty much we'll be going through them one by one. So on the next slide, there's the first learning objective is your developmental theories. Pretty much this is theories about how kids particularly, but also like people develop in general. So like develop like thinking wise, when they try to make sense of like who they are in the world. And there's a couple there. You've got your psychodynamic, and the ones I've highlighted in yellow are the ones you kind of need to know. So Erickson's, which we'll go through later, there's like 8 stages. You just kind of have to memorize them. Freud's, we'll go through it too, but it's not as examinable. And you just have to roughly know that Freud was the kind of creepy guy that thought everything was about sex. The second one is the learning theories. So the important ones there are Skinner's and Bandura's. And you would have done this last sem, so I just put in a little summary photo on the right, otherwise we're not going to go through that. So Skinner was all about the operant conditioning one, and Bandura was about that doll, like when kids or people were put in a room with like a doll, and they saw someone else like bash the doll, and the kids followed like that behavior. So it's all about the idea that people copy other people, particularly people with like positions of like authority or respect. For cognitive sort of theories, so like theories about how like our brain works, Piaget's is an important one. For ecologicals and systems, that's theories about like how we respond to like our environment. There's that really long one, which we'll go through. And then lifespan, so theories about how the different like periods in our lifespan. Baltus is an important one. All right, lovely. Next slide. So yeah, this is a table from your lectures that pretty much summarizes all of Freud's weird and wacky developmental stages. You can see like the 5 stages there, and there's kind of like a description of like what happens in each of those stages, which might be good to read through, but keep in mind you do not need to memorize this like whatsoever. The idea with Freud was that if the stages weren't met, so like, I don't know, if the kid wasn't like able to wean or something, to like get out of like, I don't know, they weren't met their needs like emotionally to be able to get off the weaning stage, then they would have like an adult problem related to that. So the adult problem was smoking or overeating. They couldn't get off being weaned, which is like being breastfed, etc. Or if the kid couldn't be like toilet trained properly, then in adulthood they were either like overly neat, so like a compensation for that, or they're like overly messy. So it's the idea that if you don't like follow the right kind of journeys, something will go wrong later on. Right, so that's pretty much Freud stuff. Next slide. Lovely. This is Erikson's. This is the one that's like really, really important. So if you're kind of to remember one theory from today, highly recommend remember Erikson's. There are 8 stages of like psychosocial development. What you have to know is the name of each stage. So it's like basic trust versus mistrust, for instance. You have to know the age, so birth to 1 year old. And you have to know what happens during that stage. So for that first one, the child, and yeah, thank you, David. The bonus side on this, so it's perfect. For the first one, you have like a child that's trying to figure out like what the world is and that the world is like safe. For the second one, it's when like your toddler is trying to figure out that they're an independent human being, so they're not like part of the mother anymore. For the third one, the initiative versus guilt, it's when the slightly older toddler is trying to develop new things and handle failure. I remember there was a question on this, either like on the practice exam or a past paper or an hour paper. We had to know like the 2 parts, so they're trying new things and able to handle failure. So like knowing those descriptions and the challenges is pretty important, because sometimes they test like, oh, what's the second part of it? Industry versus inferiority is from like school age, I guess, so 6 to adolescence. It's when you're learning basic skills like at school and learning how to work with others. Then you have identity versus identity confusion. That's in adolescence, when you're trying to develop a sense of identity and sort of who you are. Then you have intimacy versus isolation. That's in adulthood, the kind of first times you're committed to like a long-lasting relationship and trying to figure out how that works in your life. Then the middle life crisis sort of age is generativity versus stagnation. So it's either do you generate product or something, are you working towards something, or are you stagnant, are you like stopping? So the idea there is that you're contributing to younger people through child rearing, childcare, or other productive work. That's certainly like work in like your business life, like work like in your family life. And then in late life, the challenge is to view one's life as satisfactory and worth living, which is kind of sad. And that stage is integrity versus despair. This is sort of Erikson's whole thing, that you go through kind of all these stages, and you have like a challenges you're facing each of these stages. So yeah, make sure you know that. Lovely. Next slide. Piaget's focuses a little bit less across the lifespan, so it's only like from birth to adolescence. And it's a bit more about like the brain side of things before it's a bit more about like the social side of things. You do also kind of have to know the 4 stages. So if you're sensoromotor, it's like your sensory and motor stage, your pre-operational thought, concrete operational thought, and formal operation thought. So make sure you know them, and you know like the rough approximate age. So in sensory motor, it's pretty much exactly what it sounds like. The infant's knowledge of the world is based on senses and on motor skills. Pre-operational thought is when they're starting to use symbols. So like words and numbers, but only stuff they can actually tell. So like stuff they're like here and now, and you can see that in concrete operational thought as well. The difference when you get to like formal operational thought, that's like more abstract scenarios. So things like, I don't have hypotheticals about the future, that's kind of only adolescence and beyond. Things about like, even like sometimes like math can be like quite abstract as well. So that's like kind of the formal operational thought as well. So just like have a few examples obviously to distinguish between them. And you'll probably see questions in the exams about it as well. All right, next slide. Ecological, this one, I don't think it was really tested on the exam. I think it came up in the assignments. I remember having to write about it. From memory, I don't think it was really an exam question. It's sort of the idea how that your environment influences your development, and there are different like levels of your environment. So you have like the microsystem, which is like your house, the people inside your house, like your classroom, the people inside your classroom. So like very much when you're growing up, it's like kind of you and your parents and your siblings. When you get older, it might be like you and your workplace. The mesosystem is a bit big. Okay, so sorry, the mesosystem is more about like the school, like the broader school environment, and like broader like friends, peers, sort of thing. Exosystem is like a lot bigger, so it's like a secondary social network. So social network like of your friends' friends or your parents' friends, and also a bit more broader, like government policy, etc. And the macro system is like culture, religion, ethnic group you live in, historical events like COVID-19. That would be part of the macro system. Whereas exosystem might be like COVID-19 policy or something. So it just like shows how like it builds upon each other. Really came up in the assignment, kind of the main area. David?
I might just throw a question to you, yeah. So
yeah, go for it.
some of them are saying that in first semester in MoM, they learned most of these theories.
Nice.
Which we weren't. So they want to know if the questions they got in the exam about these will be on the second sem exam.
Oh, that's a good question, because we were taught the second semester.
Yeah. So if they covered it first sem, I don't think they would ask you again next sem.
No, they generally try to distinguish quite well between first sem and second sem content.
Yes, I agree. Like even year 2 right now, I did ask about if we want to get exam at all in semester 1 content, and they said no. So normally they definitely do not ask about the previous semesters. So if they did learn it.
Okay, but you need them for the assignment. So that means they've changed how they teach this a bit, which is interesting. So
that is very interesting.
If it comes up in your lectures, then come back to us and maybe write it on that Google form thing, and we'll search up with faculty for you. Definitely need them for your assignment. Otherwise, if it's not brought up, then no, you wouldn't need to know it.
Yeah, but if they need it for the assignment, I feel like that counts already if it's brought up that semester.
It's weird to not teach this the semester of the assignment.
Yeah, we've had a couple of things that were taught in both sems, especially like with mindfulness and stuff that has come up in both exams.
Yeah.
So see if this is taught in a lecture again, or given like alluded to.
And if you're still confused, ask us on the form and we'll find out for you.
We'll find out. Lovely, Peter. Next one. This is the lifespan perspective. It's more about like decision making and how you adapt to decisions. By Paul Boltz, that's his theory. You kind of need to know each theory's like name and roughly what it does. For this one, there are sort of 3 processes, kind of like operant conditioning a little bit, to be honest. So selection is when you choose a goal, or you choose an action, or choose a task. And they could be like a voluntary selection or a loss-based selection, which is like when you're forced to choose something because of circumstances. Compensation is when whatever you've chosen initially doesn't work anymore. So like for whatever reason, it doesn't work. So you have to like figure out another way to achieve your goal, or you try to adjust the goal a little bit. So like, for instance, if your goal was to make the Olympics final in the 100-meter running, and then you figured out you broke your leg, so you can't run, I don't know. In compensation, you might switch to another sport like swimming, or you might go for the Paralympics. So like you have to like, you still have like kind of the same goal, but you've adjusted a bit to suit the realities of life. And then optimization is related to compensation, but it's like adjusting it to best suit your goal again. So the example here I have in green was you might be a writer who's really good at writing novels and newspaper articles, and you choose to focus on novels because you don't have enough time to do everything. So that's a selection. That's a loss-based selection because you didn't have enough time to do the newspaper articles. So you spend all your time on a new novel for publication. So that's optimization. That's like you chose to send all your resources there, but it was rejected, so you had to compensate. So it can happen in any order, but generally it's selection, compensation, and then optimization. Lovely. Next one, Peter. This comes up all the time, I swear. Biopsychosocial factors is like every HEPA, HLSD, or MoM lecture. So it's here as well. This was just discussing the different biopsycho, social, cultural, and life cycle stuff that happens in development. Pretty much for biological, it's like all your genetic stuff. That's huge in development. Stuff before birth, like your prenatal stuff is huge. As in like, you know, how your parents' bodies are affects how you are in the womb as well. Psychological is more about like your thinking kind of processes. So your personality traits, your ability to regulate emotion, your Piaget's cognitive development, that's psychological. And on the next slide, we have some social, cultural influences, which describe how, like, you know, the social group you're part of, or the religion you're part of, or the education system you're part of, or like the culture dietary factors you're part of can influence your development. And the last one is sort of a new one. It's life cycle forces. It's this idea that you could have one event or one thing happen, but it affects people differently from different ages. So, you know, how getting Alzheimer's at 50 is absolutely devastating. Getting Alzheimer's at 85, while it's bad, is kind of less devastating because you might have more significant problems to deal with. Or you're getting cancer as a 16-year-old versus like a 90-year-old, very different. So that's just a good thing to keep in mind, that the age you are can affect how you view things. All right, awesome. Nature versus nurture, kind of related to the whole biological thing. Just reminds us that, you know, both nature and nurture are important. Your genes and your environment. There's a definition for genotype, phenotype. Hopefully you'll know that by now. Keep in mind that they say it's like 50-50, but it's 50-50 overall, but for each characteristic, it's not 50-50. So stuff like your height is more genes than environment, but stuff like your weight is more environment than genes. So like all up it's 50-50, but it's just each characteristic isn't. And there's an example here about personality conditions, and pretty much how likely you are to be happy is only 20% genetically determined. 80% is environment. But like, for instance, how likely you are to be like, to have anxiety is about half environment, half genetics. So it's just a good example there. And then moving on to our next lecture series about the newborn and early childhood development. There are the learning objectives there, and we'll just go through them. The first one was to name newborn reflexes. I literally do not remember this coming up whatsoever. David and Peter, correct me if you had like 10 exam questions on this, because I did not remember this at all. Yeah?
I think Babinski did come up a little bit.
Yeah. I feel like that would be the only one, but yeah.
I think Palmer came up even less, but I just, yeah, I know Babinski.
Babinski. So Babinski is like when you stroke the baby's foot. Usually like you go from here and you kind of go like across the toes, like up like there, like just laterally. And the idea is when that happens, the toes is kind of like just spread out and kind of go backwards a bit to like fan out. And the logic behind that was it was like an evolutionary thing, a mechanism of the past. As Babinski, and then Palmer is just when you place something in the palm, they grasp your palm. And like usually this happens with like a thumb, like they'll place like a thumb in your palm and like you grasp the thumb. And that's like related to walking. It's like when you put your foot down and like you have to like grasp like the ground with like your toes. So I guess those are the two that we seem to remember coming up. Feel free to like read through the others, but I highly doubt they're really not that important. All right, this one objective was more about like personality. The idea that temperament, which is basically personality, depends on both genes and environment again. There was this research criteria that Rothbard made up to determine like personality, and he looks for like 3 things. The first is like extroversion, which is like how happy, vocal, energetic the baby seems to be. Second, he called negative affect, which is like all the negative emotions. The third one was effortful control, how well the baby can work, focus, have an attention span for. Interestingly enough, for genetics, the negative stuff seemed to pass along more strongly. So if the parents had genes where they were like naturally more angry, the baby tends to be more angry. Whereas if the person has genes where they're naturally more happy, that doesn't necessarily get passed on. So interesting. Next one. Lovely. This learning objective is all about physical and motor development. I pretty much have like a rough sense of idea about the big milestones, which I'll show on the next slide. But in terms of physical development, babies grow really fast. It's the fastest period they ever grow in their entire lives. They double their weight by 3 months old, triple it by the end of the first year. And nutrition is super important. And the best nutrition for babies is breastfeeding. Formula, whilst comes close, is not the best, so breastfeeding. Babies have better hearing. Babies have better smell and better taste than adults, but worse hearing and worse eyesight too. So smell and taste, which makes sense because like in their womb, they kind of develop smell and taste, whereas they don't really develop hearing or eyesight until like later on. And on the next slide, you have like all the big sort of physical milestones. I would kind of, if I were you, I'll maybe learn some of the fine motor skills there, potentially that the fact that they can't really do much until about 5 months, where they can sort of move their 2 hands. And then they can only use a zipper at 2 years old, but they can't use buttons yet because that's too fine. And then maybe something like, the first time sort of walking. So that's at 11 months there, walking when led or walking by themselves at 15 months. So just kind of learn, just like the rough guidelines. They'll never ask you for sure, like when do they start walking? But they might be like, oh, the baby is walking. What stage are they on like Erickson's developmental model? So you just have to know like, 15 months on this stage, it was this. So that's that slide. Sleeping, babies sleep a lot. That's what they do most of the time. They sleep like 2/3 of the day, but they don't sleep consistently. They have to wake up pretty much every couple of hours to be breastfed. So yeah, they sleep in a 4-hour cycle, 3 hours sleep, 1 hour wake. Or by 3 to 4 months, it's a 5 to 6 hour sleep cycle. And by 6 months, they're sleeping 10 to 12 hours a night. Prenatal development is super important for children, particularly a lot of the harmful stuff can come through. So the biological factors here are like hereditary conditions, age of the mother, massive. A woman in her 40s has a miscarriage about 50% of the time. And alcohol, like you cannot have alcohol at all when having kids. It is a massive, massive bad effect. Please do not have alcohol when you're having kids. And same with drugs. Below there is a table. In your lectures, they've included a bunch of questions on the drugs, which is interesting because I've never seen it come up like an exam question, apart from alcohol comes up, but the other drugs don't. But they had exam questions in the slides. That's why I thought I would include that drug table here. Psychological stress of the mother or whatever the mother's experiencing can affect the child because it affects the hormone levels. And social factors on prenatal development is stuff like education, how well do the parents know what you should do about the baby in the room, and finances. Can they afford, getting tests? Can they afford getting like supplements? That's a huge factor as well. Lovely. Next slide.
Okay, I can't
I
skip this
figured.
slide. Okay, I'll stop sharing. Could you start the slideshow? I think
Yeah.
Chrome's like.
Oh, good, oh, good.
What the hell? That's weird.
They just like start crashing on you.
Yeah.
Can you enable share screen?
Or make Cutro host.
Oh, true. I spoke about this. Look, I'm still sleeping. Lovely. Oh, mine doesn't. Is that the last slide? Mine doesn't go further as well.
Oh, it must be.
Oh, maybe that's why. Oh, never mind. I was so excited. That's it.
Oh, okay. I was like, okay, it wasn't my computer.
No, it wasn't your fault.
How tired are we? Do you think you can do some more? Let me know. Maybe thumbs up if you can do more, and what other reaction? And laughing face if you need a break. Oh, wow, look at you.
Hermit.
I would not have said yes. Very impressed.
I'm impressed. They're very keen.
Okay, let me share my screen. So thankfully, this physiology, while quite difficult, is not very high yield. I got my second vaccine yesterday, so don't worry. This topic is, I didn't make these slides, by the way, just to point out, Andrew made these slides, but he's not here today, so I will present them. This topic was ridiculous. I think this is the hardest lecture I've ever had for anything. It also didn't show up anywhere, not even like referenced. So yeah, Andrew is there written, it's low yield, and essentially that he doesn't really get it. So it's pretty tough. To begin with, if you can remember from last week, the brain is divided in different cortexes, and these cortexes communicate with each other in order to coordinate either movement or sensory information and integration. Some of these areas, such as the primary motor cortex or area 4, is where outputs go down to upper motor neurons, which synapse into the spines and go into the corticospinal tracts to execute movements. Other supplementary motor areas, such as the premotor and supplementary motor areas, can be involved in sensory guided movements. So it takes sensory and motor information to plan the movement, and then that is later executed. Or in the supplementary motor division, it has further divisions where it can plan motor actions really related to memories, whereas others are involved in acquiring new sequences for the coordination of movement. I lied before. There was a question on the primary motor cortex and how it goes to the cortical spinal tract in one of the practice exams. Tough stuff. Just know these interact. Really, SMA and PMA contribute to M1 to be taken down the descending track to execute motor movement. Okay. I'm not doing well. I'm fine, don't worry. This is now referencing the paired structures on either side of the brain in reference to the basal ganglia. So the basal ganglia has many constituent areas: the globus pallidus, the putamen, caudate nucleus, and these three form a striatum, as well as subthalamic nucleus and substantia nigra. I learned all of this, and it was no reason to have learned it. The only thing I learned that was interesting is substantia nigra is involved in Parkinson's, but really not much more to it. These are involved in further in helping to coordinate movement. This is a very scary looking loop. It's referencing a direct pathway, which is a positive feedback loop, which means it facilitates the cortex to make movements. So if we start at the start over here, we have a structure called the ventral lateral nucleus, and it constantly wants to fire. So there's an electroset, it's like an overactive puppy, and it constantly wants to stimulate the motor cortex. And when something constantly wants to fire, it's called tonic. So it always wants to stimulate the cortex, and by stimulating the cortex, it initiates movement. That will then go to the striatum, And there's a feedback loop. So this will go to the cortex. Cortex will initiate movement, and at the same time, it'll feed to the striatum, stimulate the striatum. And the striatum has the function of inhibiting these two structures, which is the globus pallidus interna and substantia nigra. And by inhibiting, the green lines here are inhibitory. If we start here, by inhibiting this excitatory, this is inhibiting VLO. VLO excites the cortex. If you increase the inhibition of this, you're decreasing the excitement. If you decrease the inhibition of this, you're increasing the cycling. So here we are increasing the inhibition of this. By increasing the inhibition of the inhibitor, we're increasing the excitement of the cortex. I'll say that again. You are decreasing, you are inhibiting GPI and SNR, which are involved in inhibiting VLO. So if you're decreasing the amount that is inhibiting, you're leading to further excitation. Does that make sense? So by inhibiting this, you're inhibiting this, so it's going to excite the cortex. Tonic means it's constantly firing. I hope that makes sense. Indirect pathways, how you inhibit unwanted movement. There's an added component here in which the GPI and SNR are excited. By exciting them, you increase the activity of these structures. By increasing their activity, you're having more inhibitory effect on VLO and less motor movement. GPI and SNR are involved in Parkinson's, where there's problems in inhibiting unwanted movement. And because that means that these structures aren't working, there's less of an inhibitory signal, which means it's overacting the cortex. This is really hard, so do tell me if you have questions. Now, for some reason, we stop talking about that and we start talking about the cerebellum, which is involved in coordinating movement and balance. It's involved in timing and looking at the external sensory information, seeing if there's a disregard with the motor signal and what you see the body doing, and then correcting for that. The cerebellum has anterior, posterior, and flocculenta lobe. Anterior, posterior, flocculenta. I wouldn't waste time learning that. Oh no, if you're interested, definitely learn it, but it wasn't in the exam. There's also a medial, intermediate, and lateral zone, as well as the vermis. Yep. The vermis is the midline structure, but then the rest are in the name. The vermis controls the movement of the axial body, neck, shoulders, and hips in your midline. So usually proximal structures control proximal structures, intermediate contractions of distal portions of the limbs, and lateral zone is in the overall planning of sequential movements, important for timing. Really, that is a very complicated lecture and really low yield. I remember seeing a question talking about the reference to Parkinson's and GPI and SNR, I think, but that was quite a long time ago, and it's probably worth getting that wrong and having to understand all of it. Sliding filament theory, I kind of also don't want to waste your time, but actually it's helpful to hear it again. So an action will travel down T tubules, which will distribute the signal through the sarcoplasmic reticulum of the muscle, which is where all the calcium are stored. The triggering of the potential down the T tubule releases the release of calcium channels, which release calcium ions. Calcium ions will proceed to bind to troponin, causing it to pull tropomyosin away and exposing the actin. As a result, at the same time, myosin is being cocked with ATP. So ATP is converted to ADP and P as storing energy. And it becomes reorientated. Then the myosin head binds to actin because the calcium has been removed, unwinding the troponin. It binds to troponin, unwinding the tropomyosin. That's been removed. So there's a filament kind of striking the head, binding to the actin, myosin actin cross bridge that pushes towards the filament and continues to cycle in that way to create muscle contraction. Hopefully that's all sounds familiar. This is telling you the T tubule and the cytosol, how that works. You have dihydropyridine receptors. This is quite important, which are voltage gated calcium channels, which open in response to an action potential. So an action potential will throw through here. It'll stimulate the hydropyridine receptors, which are coupled to the ryanodine receptors, which are involved in the release of calcium from the sarcoplasmic reticulum into the cytosol. And then after the contraction has occurred, ATPases will pump calcium back. And if you regulate your contraction either through rate coding, which is the frequency of it, that means that there's more time before the calcium is all taken reuptake back, so the contraction will be stronger. I hope that wasn't confusing. You don't need to know that. You just need to know these words. Dihydropyridine receptors are coupled to ryanodine receptors, which are involved in calcium release. Calcium is an active process of being reuptaken into the sarcoplasmic reticulum. These are words you should know. I'd say this is the most high yield thing because it's new. Isotonic, the word isotonic refers to muscle changes length while maintaining constant tension. So they're lifting a ball, the muscle is changing length, but the tension is the same. Isometric refers to the development of tension without changing length, which is whenever I try to pick something up. So it's when the object is too strong for your muscles to actually pick up, so you're putting tension, but nothing is changing. There's two types of isotonic contractions. Eccentric is when the biceps muscle is lengthening while contracting. Peter gave a clinical example of this, referring to the biceps brachii, that muscle snapping. So it's when sometimes eccentric can lengthen, and that's okay while contracting. So you can tense your forearm and then pull it down while tensing it, or you can push against a force that's pushing it down. Sometimes that can damage and tear the muscle, but that's also how you build more muscle mass. That's what people do when they go to the gym. Concentric is when the bicep is shortening while contracting, which is easier to conceptualize. Length-tension relationship, as you know, the overlap between actin and myosin. If there's more overlap, that means you're going to have a stronger contraction. If they're too overlapped, that means you're losing sort of surface area, so this contraction won't be as strong. And if there is no interface, then they won't slide over each other and there will be no force. Twitch contractions are single ATPs. They last longer than an action potential, of course, because there's time for that whole calcium release, but they're not really too significant. Summated contractions is as the action potential is brief, you can have another action potential be produced while the muscle is contracting, and they will summate the frequency. That's called rate coding. The S signify when AP occurs in the diagram. So here you can see this is the increased frequency of action potential stimulation. So before the stimulation at 200 has gone down, you've had another one. Now the stimulation is going to go up, and that's going to become more than a twitch. It's going to start to summate. Tetanus, as we've talked about before, when muscles are repetitively stimulated, they can either choose titanic or tetanus contractions. This is a twitch, which is one action potential. If you have a higher frequency, they can be unfused tetanus. There's a bit of an oscillation, so you would see that as a bit of a tremoring. And when you have lots of stimulation, you get a fused tetanus, which is completely strong movement. Motor units, we talked about this last week, so I'm going to go through this very briefly. Motor units are muscle fibers. So you have a motor unit, you have an alpha motor neuron, and the motor unit is all the muscle fibers that it innervates. You're going to recruit smaller units first, and then larger units will be recruited afterwards. The reason why is that the more soma, or the cell body, the greater resistance, so you need more kind of energy in order to stimulate it. Smaller units are generally fatigue resistant. Larger units actually usually pack more energy and usually fatigue a little bit more. Yeah, and it allows the gradient of our strength. That's all we have here. So thanks everyone for your time today. We're going to now talk about, I think,